So we'll be starting with the day 2 of our PG orientation, and this will be a discussion on the case of thyroid swelling, and it will be taken up by Dr. Professor Utpal Jana sir. This again has been divided into 3 parts. The case presentation, then we'll be having discussion, and the last will be the specimen part. It will be taken by Dr. Pranavashish Banerjee, Dr. Prashanto Gure, and Dr. Animesh Ghosh.
So let us start. Very good morning to all you. We will start the first thyroid case presentations. So usually the history is the name, age, sex, religion, residence, occupations. These are very important, and also the chief complaints. The most common presentation is a painless swelling in front of the neck for a sub duration like 7 years. So along with chief complaints, the other chief complaints may be like you have to ask for any difficulty in swallowing or any hoarseness of voice or any pain or any other toxic general symptoms. So these points we have to ask, and you have to note, you may note if they are present during the chief complaints. Next, the history of present illness. So my patient was apparently well 7 years back. Then she developed a globular swelling over the front of her neck, midline, which gradually increased in size to its present dimensions in the middle part of the neck. The swelling is painless and moves with deglutitions, but not with tongue protrusions. Patient does not have any hoarseness of voice, difficulty in swallowing solid and liquid food, or difficulty in breathing. There is no history of sudden increase in size of the swellings. So during the history of present illness, so you have to ask how the onset of swellings, as usual onset, then it is whether it is a sudden onset or it is a gradual in onset, and how it is progressing. Whether it is rapidly progressive, then it may signify that there may the chance of malignancy is there, or there may be sometimes hemorrhage in the nodule, which may cause sudden increase in the size of the swellings. And along with, you also note whether there is other symptoms, like whether the swelling is moving with tongue protrusions or with deglutitions and in hoarseness of voice and other symptoms. Next, the history of past illness. The patient does not have history of any significant illness in past. Patient does not have any history of diabetes, hypertension, asthma, or tuberculosis, and patient has no history of radiation exposure to head, neck, and chest. I think this is the most important point in case of thyroid, the history of radiation exposure to head, neck, and chest, because they have some bearing with the thyroid cancers. So this is the most important thing in past illness. The personal history. The patient is non-vegetarian and consumes mixed Indian diet. Patient does not smoke, does not consume tobacco or alcohol. Patient's sleep and appetite are normal. Patient's bowel and bladder habits are normal too. Patient has no history of change in weight or intolerance to heat or cold. Patient's socioeconomic status is average. Patient is GP54 and has regular menses. She had undergone bilateral tubal ligation 10 years ago. So personal history is the most important for thyroid cases. Will be in the bowel and bladder habits and history of change in weight or intolerance to heat and cold, because they may present thyroid swellings may present with hyper or hyperthyroid features. So these are the important points to note during personal history. Next, family history. Patient does not have any history of any similar illness in family except in a distant relative. There is no history of similar illness in the neighborhood. Both of our parents died of not natural causes. So this is also very important. The family history of same disease, like thyroid disease. And usually in case of medullary thyroid carcinoma, it may runs in the family. So this is the most important thing in the family history. Also the neighborhood and drug history. Patient has no history of drug intake. Patient does not have any known allergies. So drug is also important. Whether the patient is from drug history, we can elicit anything. if whether patient is hypertension or diabetes, or patient is euthyroid or hypothyroid or hyperthyroid. So from the drug history, you can know all the things. So this is very important. Next, the general survey. Patient is conscious, cooperative, and oriented with time and place and persons. No pallor, icterus, cyanosis, clubbing. Carmel score and ECOG is not so important. Pulse, BP, respiratory rate, affably, no pigmentation or scar. General survey. Inspection, this is the most important thing. You first note that the butterfly shaped swelling, when there is a diffuse swelling of the thyroid, so it takes the shape of a butterfly. So butterfly shaped swelling is present in front of the neck, in midline, in thyroid region, extending bilaterally. What is the extension is noted from one sternomastoid to other. This is very important. And in the above to the upper border of the thyroid cartilage, and below to the suprasternal notch. So these are the four important landmarks for describing the extent of the thyroid swellings. Superiorly up to the thyroid cartilage and inferiorly up to the suprasternal notch with dimension as follows. So you will measure the swelling with the tape and you note it in centimeter. The swelling moves with deglutitions and lower margin of the swellings can be visualized on deglutitions. The swelling does not move on trunk protrusions. This swelling does not move with trunk protrusions. This only usually required when there is a nodular swellings in the thyroid. No, in other cases, when there is a big thyroid swellings in the shape of a butterfly, you don't do this test. There is a venous prominence over the swellings without any visible pulsations. And no signs of sympathetic trunk involvement like Horner syndromes are present. So these are the inspection. Then this is the swellings. So then palpations, the inspectory findings, the extra two findings are temperature and tenderness. So whether findings there is other findings we have noted in case of inspections that should be corroborated again to the temperature over the neck swelling is normal and swelling is non-tender. Then other swellings has a smooth surface and defined margins. It has a soft consistency with no pulsations and thrills. The swelling has mobility in horizontal plane without independent upward mobility, and its lower margin can be palpated. The swelling is not fixed to the overlying skin. Circumference of neck at most prominence is 42 centimeter. Trachea is central in position, and Cocker's test for tracheal compressions is negative. Carotid pulsations are palpated bilaterally at normal site, and since Berry's sign is negative, none of the cervical lymph nodes groups are palpable. Percussion. On percussion over manubrium sterna is resonant note is obtained. Auscultations, no bruit is audible over the neck swellings. So examination for toxic signs and examination for retrosternal prolongations. We will note these. Then the nervous system, cardiovascular system, respiratory systems, and abdominal examinations, and then case summary. So my advice to you, for every case, long case or short case, you just make a ideal history in your notebook. And when there will be a case, you will just additional alterations to this case history. So no extra points or no other things should be mentioned, or no new things should be mentioned during this examination history. Okay, that is a very important point. And the case summary, you also note this, just if the swelling is a very small one, nodular one, just change to just a nodular swellings. Size is different and mentions the other things as usual. Just change it. So case summary, this is, you have to tell this to the examiner. So this 40-year-old female presented with a painless swelling in front of her neck in midline, which has enlarged gradually over last 7 years. She does not have any hoarseness of voice, dysphagia or dyspnea, and the swelling moves with deglutitions but not with tongue protrusions. There are no symptoms pertaining to nervous, cardiac or respiratory systems. She has a normal appetite, sleep pattern, bowel habit and menstrual cycle. There is no history of similar illness in her family or neighborhood. And on examinations, general survey is normal. On local examinations, a butterfly-shaped swelling in front of neck, in midline, extending up to sternomastoid bilaterally, thyroid cartilage superiorly and suprasternal notch inferiorly is present, suggesting it to be a thyroid swelling. It has a smooth surface, soft consistency, is not tender, mobile and not fixed to the underlying or overlying structures. Trachea is in central and bilaterally carotid pulsation palpable at normal site without any cervical lymph node enlargement or signs of sympathetic trunk involvement. There are no signs of thyrotoxicosis or retrosternal prolongations. So provisional diagnosis, this is probably a case of non-toxic colloid goiters. So this is an ideal history. So it may to take some changes when there is a swelling is very nodular or some other things. So this is a proper usual ideal history of in case of thyroid swellings. Now I will request Dr. Prashanto Gure to take some things like the clinical examinations, and you can put the questions to the students.
Achha, first, the clinical examination. In clinical examination, important part is the general survey. What are the important points you look for the general survey in case of thyroid swelling? Any volunteer, একজন বলো যে কেউ? What are the special general survey particularly important for the thyroid swelling? Anyone? Huh? আচ্ছা একজন, আচ্ছা 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 ও বলো।
Tachycardia or if there's any
Pulse.
yes,
No, so
pulse.
pulse. What are the important sign and symptom? Look for the pulse.
So we look for the rate, rhythm, volume, and regularity, whether it is regular or anything else.
Is there any tachycardia or bouncing pulse?
Bouncing
Particular night
pulse,
pulse
yes.
is important. This is not
Yes,
possible in case of examination. So pulse is important.
pulse is important.
And there is a very important point is the facies. There is a two type of facies present in the thyroid case. One is the myxedema facies. Obvious question will be the what are the features of the myxedema facies? One is the thyrotoxicosis facies. So what are the myxedema facies?
So there will be puffiness of the face, baggy eyes, and
Anyone? একজন একটু ভলান্টিয়ার করো ওকে, তাহলে ক্লিয়ার হয়ে যাবে যে কেউ।
Sir, in cases of myxedema, the skin of the face will be thicker and there will be swelling of the face and eyelid edema will be there. And in cases of thyrotoxicosis, you will have the signs of ophthalmic signs will be there along with thin skin, sir.
আচ্ছা ঠিক আছে। Apart from the faces, then the pulse, faces, and then the neck glands.
Yes, sir.
How will you palpate the neck gland?
How will we? Sir, there are three methods to palpate the thyroid gland. One.
Thyroid gland now, only the neck gland. That is the lymph nodes.
Oh, lymph nodes. Sir, I will stand.
This is the general survey. It's obviously lymph
Yes,
nodes.
sir. We'll stand behind the patient. We'll ask the patient to rotate the neck towards the one side, and then we'll palpate on the one side of the.
First, the flex the neck.
Yes, sir.
And
Slightly
then,
flex the neck. Then after that, we will ask the patient to turn on the other side. We'll flex on the flexion side. We'll first palpate the lymph nodes. Then we'll
How
go.
will you palpate?
So with the help of fingertips.
Palp of the finger.
Yes,
So
sir,
always
palp.
the palp of the finger, and then
And then we'll note which level of lymph node is involved in the thyroid swelling. Usually in cases of thyroid swelling, the level 6 will be involved. And
now you have to examine all the lymph
Yes,
nodes
sir.
from the level 1, 2, 3, 4, and 5 and 6.
Yes, sir.
All.
Yes.
So general survey is almost complete. ঠিক আছে, next হচ্ছে how will you palpate the thyroid swelling? What are the methods?
There are three methods to palpate the thyroid swelling. One is the standard method, another one is Lahiri's method, and another one is.
What is standard method?
So standard method is we will stand behind the patient with the help of fingertips. We'll ask the patient to slightly flex the neck, and we'll.
Is there any name for this test?
I don't remember the name, sir.
আচ্ছা, back মানে from the behind there is no name.
Okay.
From the front there is a different
Yes,
name.
Lahiri's and one more is there.
মানে what will be the preference? Particular this case, pertaining to this case. It's a non-toxic goiter, single nodule.
Lahiri's method.
Lyas method. Describe the Lyas method.
So we'll ask the patient to sit in an upright position.
First introduce yourself to the patient.
Yes, sir.
And explain to the how will you do it.
Okay, sir.
মানে make a
After-
rapport to the patient.
Yes, sir.
হ্যাঁ।
After taking
Then
consent
patient will relax. Relax না হলে না muscle relaxation cannot palpate is a small
Yes.
thrilling.
So after taking consent of the patient and after explaining the entire procedure to the patient will be made to sit in a upright position with the neck little flexed, and we will be sitting in front of the patient. With the help of fingertip, we will press one side of the thyroid lobe.
Now, if you examine the left side, how will
Yes.
you?
So if I'll examine
In
the
LAS
left,
method.
if I'll examine the left side, then I'll use my right hand to push the swelling onto the left side, and with the help
To
of
make it prominent to
Yes,
the
sir.
left side of the swelling, then
yes, sir. And with the help of my fingertips, I'll palpate the
which part of the finger? This is the tip of the finger.
pulp of the
It's
fingertip.
a pulp.
Yes,
So
pulp of
palmar
the
surface of the finger should be used for the palpation of the
Lyre.
thyroid. This is the LAS method. And then
So there is one more method.
আরেকজন বলো, from the behind. There is no name from the behind. ঠিক আছে?
So two other methods, Cryle's methods and Pizzolo's method. Cryle's method, we do it for a small swelling. We will only press the swelling with the thumb. And in Pizzolo's method, in case of any short neck or obese patients, we need to make the thyroid more
Describe the
prominent.
Pizzolo's method. What is the indication of doing the Pizzolo's method? That is important question.
So obese and short neck.
It's a obese patient and short neck patient. Then it is obvious, better to do with the Pizzolo's method. What is this Pizzolo's method? Describe.
We will need to make the thyroid gland more prominent. So we will ask the patient to place both his hands and push in the occiput region and push it forward. And the head needs to be a little bit extended.
Examine from the front or behind?
Examine from the front.
Front. না behind দিয়েও করতে পারো, মানে দুটো, কোনো there is no hard and fast rule. ঠিক আছে, this is the Pizzolo's method. ঠিক আছে, একজন Cryle's মেথডটা বলো, what is Cryle's method? What is the indication of the doing the Cryle's method?
Cryle's method is used for small swellings. So basically we stand in front of the patient and we will put our thumb on the small swellings.
Which part of the thumb? Which part of the thumb?
Pulp of the thumb.
Pulp of the thumb.
And we will ask the patient to deglutition.
Swallow.
Sir.
And see the movement of the.
Yes, yes.
This is the all method. ঠিক আছে, আর কোনো কোশ্চেন আছে এখান থেকে? Examination of thyroid. ঠিক আছে, নেক্সট কোশ্চেন উইল বি, তোমার তিনটে মেথড হয়ে গেল, লেস মেথড ফ্রম দ্য ব্যাক, Pizzolo's মেথড অ্যান্ড হচ্ছে লেস মেথড হয়ে কমপ্লিট। নেক্সট হচ্ছে হাউ উইল ইউ প্যালপেট দ্য ক্যারোটিড pulsation and which part should be the palpated?
Carotid is palpated on the superior border of the thyroid cartilage along the anterior border of the sternocleidomastoids. Only one carotid at a time.
What is the importance of the palpating the thyroid? Thyroid বলছি, carotid pulsation.
In case of malignancy, sir, the malignancy may invade the carotids, and that's basically the Berry's sign positives.
What is Berry's sign? একজন বলো, হ্যাঁ বলো।
So in case of infiltration of the carotid sheath, on that side, if we try to palpate the carotid pulsation, it will be absent. That is Berry sign positive. And if we get the carotid pulsation, that means Berry sign is negative.
Very good, ঠিক আছে। আচ্ছা, নেক্সট একটা খুব ইম্পর্টেন্ট কোশ্চেন জিজ্ঞেস করেছে, অল থাইরয়েড সোয়েলিং আর মুভ উইথ ডেগ্লুটেশন, আর হোয়াই দ্য থাইরয়েড সোয়েলিং মুভস আপস অ্যান্ড ডাউন উইথ দ্য ডেগ্লুটেশন? মানে পুরোটা ডেসক্রাইব করতে হবে।
Sir, thyroids are enclosed with the middle layer of the pretracheal fascia. That's why it move with deglutation.
না, আরও ডিটেলস বলতে হবে। এইটা জাস্ট ভেরি, মানে কি বেসিক কোশ্চেন, আন্ডার গ্র্যাজুয়েট কোশ্চেন, বাট ইন পোস্ট গ্র্যাজুয়েট এক্সামিনেশন এটা কিন্তু অনেক ডিটেলিং বলতে হবে, যে হোয়াই দ্য থাইরয়েড সোয়েলিং ইজ মুভস আপস অ্যান্ড ডাউন উইথ দ্য ডেগ্লুটেশন। ও বললো কি এনক্লোজ বাই দ্য প্রিটেকিয়াল ফাসা, ইটস ভেরি গুড। Then pretracheal fascia posteromedially condensed to form the Berry's ligament. And the Berry's ligament attached to the cricoid cartilage and the other part of the larynx and the trachea. Then during deglutition, the cricoid cartilage and the larynx whole moves ups and down. That is why the thyroid gland, thyroid swelling is move up and down during the deglutition. What are the condition where the thyroid swelling does not move up and down with the deglutition?
Sir, if there is huge thyroid swelling, second,
huge goiter.
Huge thyroid swelling. Second, sir, if there is retroexternal extension, then also not move. And If there is soft tissue involvement,
If there's a locally
yes,
advanced thyroid
Advanced
swelling,
thyroid swelling.
thyroid carcinoma, infiltration into the surrounding structure, there is
structures.
no. আর একটা রিডেল থাইরয়েডাইটিস বলে একটা আছে,
হ্যাঁ,
সেটা
রিডাল
তো-
থাইরয়েডাইটিস স্যার।
ঠিক আছে। আচ্ছা, নেক্সট কোশ্চেন, অনেকগুলো কোশ্চেন আছে। হোয়াট ইজ, স্যার এখানে একটা জিনিস বলেছে, ইন সাম কেসেস অফ অ্যাডভান্স থাইরয়েড carcinoma there is a chance of involvement of the sympathetic trunk in the look for the Horner syndrome.
Yes, sir.
What is Horner syndrome, or what is, what will we look for?
স্যার
একজন অন্য কেউ বলো, যে কেউ, আরে দেখেও বলতে পারো, কোনো অসুবিধা নেই। মানে ভালো বললে এই কোশ্চেনগুলো জিজ্ঞেস করতে পারে, যখন তুমি ভালো বলবে তখন এই কোশ্চেনগুলো জিজ্ঞেস করবে।
Presence of ptosis, absence of sweating, absence of ciliospinal reflex.
আচ্ছা, আর একটা ভেরি ইম্পর্টেন্ট থিংস, ডিউরিং দ্য থাইরয়েড এক্সামিনেশন ইউ হ্যাভ টু আস্ক ফর এনি, দুটো জিনিস তোমাকে সঙ্গে নিয়ে যেতে হবে, সেটা হচ্ছে 1 tape in centimeter ফর দ্য মেজারমেন্ট অফ দ্য সোয়েলিং, আর 1 is the স্টেথোস্কোপ ফর দ্য অসকালটেশন। ঠিক আছে, ইএনটিতে অসকালটেশন খুব একটা লাগে না, বাট থাইরয়েড সোয়েলিং দিস ইজ মাস্ট। ঠিক আছে, হাউ উইল ইউ অসকাল্ট দ্য থাইরয়েড সোয়েলিং, মানে হুইচ পার্ট অফ দ্য থাইরয়েড সোয়েলিং শুড বি অসকাল্টেড অ্যান্ড হোয়াই?
Central
Sir, we auscultate the superior pole of thyroid
Why?
because the superior pole, the direct supply for the superior thyroid artery, that is a highly vascular and direct origin from the external carotid artery. The high vascular and vascularity is more in the superior pole.
আচ্ছা, এখানে আরও কিছু কোশ্চেন হতে পারে। অন ইন্সপেকশনে হোয়াট আর দ্য লুক ফর, ইন্সপেকশন, প্যালপেশনে হোয়াট আর দ্য লুক ফর, ঠিক আছে, দেন দ্য অসকালটেশন, ঠিক আছে, সব জিজ্ঞেস করতে পারে। হোয়াট আর দ্য ইম্পর্টেন্স অফ দ্য অসকালটেশন,
Sir, it,
মানে why auscultation is important in thyroid
in
swelling?
auscultation there is, if there is thyroidoscosis, then there will be the bruise present in the case of thyroidoscosis.
আচ্ছা, how will you ascertain there is a retrosternal extension of the thyroid? From the history, from the clinical examination, from the auscultation. তিনটে আলাদা আলাদা করে জানতে হবে। সবারই বলো।
Retrosternal extension, first on
What will be the history?
history.
Positive history of retrosternal extension.
So there can be respiratory distress or breathlessness. Patient can present with stridor also, and on in first patient on inspection we will palpate the thyroid gland and insinuate our fingers between the suprasternal notch and the thyroid gland. If we can insinuate, then there is no extrasternal extension. But, and we can do Pemberton sign. We can ask the patient
What
to
is
lift,
Pemberton sign? This is very important.
we
Describe
can-
the Pemberton sign.
we can ask the patient to lift both his hands with the elbows touching both the ears, and then we can wait for 2 to 3 minutes, and we can see if there is any venous congestion or any conjunctival congestion or puffiness of the face, and the patient has any respiratory distress, then the sign is positive. So we can do a CT scan of the neck. Then
না,
we,
সেগুলো তো ইনভেস্টিগেশন, শুধু ক্লিনিক্স। তুমি পারকাশনটা বললে না।
percussion, direct
Normally is a
percussion on
resonant
the.
in case of retrosternal extension.
We can do direct percussion of the manubrium surnine, and if it is dull in sound, then it will cause retrosternal.
আর একটা ইম্পর্টেন্ট কোশ্চেন হতে পারে ভালো বললে, সেটা হোয়াট ইজ ককার সাইন, মানে হোয়াট আর দি ইম্পর্টেন্স অফ দ্য ককার সাইন, জানো? কেউ জানলে বলো একজন, ওদিক থেকে পেছন থেকে কেউ বলো না, সবরই বলো, সবরই না, ইয়ে দিব্যা বা ওই হাত তুলেছে, আমি জানি না নাম ওর, তুমি বলো। হ্যাঁ, তুমি হাত তুলেছো, ওই সবার ওই দিব্যা পেছনে দিয়ে দাও।
Sir, in case of a large thyroid swelling, if we press the thyroid gland against the trachea, the patient will have stridor. That is a positive Cocker sign.
বেরিস সাইন হয়ে গেল, ককার সাইন হয়ে গেল, পেম্বারটান হয়ে গেল, পড়ে থাকলো যেগুলো হচ্ছে আই সাইন। দের আর ডিফারেন্ট টাইপ অফ আই সাইন ইন কেস অফ টক্সিক গয়টার, ঠিক আছে? হোয়াট আর দ্য ডিফারেন্ট টাইপ অফ আই সাইন? এক একজন একটা করে নাম বলো, একটা করে ডিসক্রাইব করে জাস্ট, তাহলে কমপ্লিট হয়ে যাবে। বলো।
Mobius is for convergence, মানে
কি করে কনভার্জেন্স কিভাবে দেখে ওটা বলো আর ইম্পর্টেন্সটা কি?
Sir, we'll ask the patient to look far, then suddenly we'll put our finger in front of the patient's eye, this eyes, and if we see any convergence, then if it's not there, then we will say that the Mobius sign is
which convergence, lateral or medial?
medial convergence. Medial convergence.
Loss of medial convergence, positive is the
Then
Mobius
another
sign
is the sir that Geoffroy sign positive, that that occipit, frontal belly of occipitofrontalis, if the muscle, if it is in cases of hyperthyroidism or thyrotoxicosis, this thing will not be formed in the patient. So it will be the Geoffroy sign positive. And then with the Stilwax is the lead lag. So the lead lag is normally
না লিড ল্যাগ না, ওটা ভন রাখছে। লিড ল্যাগসের অন্য একটা নাম আছে।
আচ্ছা sir, I think I have messed up, means
ঠিক বলো না রে, বললে ভুল বলবে, এছাড়া আর কি করবে? ভুল বললে কোনো অপরাধ না, বলছো তো, মানে অনেকে চুপ করে থাকলে মুশকিল, কিছু একটা বলতে হবে। তুমি বলো তাহলে, সামনে যে বসে আছে ওকে দাও। হ্যাঁ,
Stelvak sign is infrequent blinking.
তোমার বন্ধুরা শুনবে, আমরা শুনে খুব লাভ।
Sir, Stelvak sign is infrequent blinking. Mobius sign is done, and
স্টেয়ার লুপ, ইনফ্লুয়েন্ট বিকলে স্টেয়ার লুপ। হ্যাঁ, দেন
and sir, there is a von Graffi sign. There is the forehead crease is absent, and there is a Dalrymple sign. That is the lid lag, Mobius sign, and Stelvak sign. And there is a Geoffroy sign, in which the forehead furrowing is not seen.
আচ্ছা, how will you look for the exophthalmos? And how will you
Sir,
examine the exophthalmos patient?
Sir, we have to stand behind the patient, and then we ask the patient to look in front when the
Slightly extend
slightly extend the neck, and then we ask the patient to look in front. If you can still see the upper
looking for what structure? There is a specific structure you have to look for.
upper palpebral fissure, upper palpebral
margin of the eyelid.
eyeball.
Then
Then exophthalmos is present. We can say that
in case of if the both the superior, মানে কি কি দেখবে? আপার মার্জিন তো দেখলে, এবার সেখান থেকে কি দেখবে?
sir, the margin.
তুমি ঠিকই বলছো।
হ্যাঁ স্যার, মার্জিন মানে স্যার আমরা আইবলটা স্ক্লেরা will be visible.
হ্যাঁ, superior sclera আর inferior
Superior
sclera
sclera
দুটোই
will
তুমি
be
দেখতে
visible.
পাবে। What are the name of this method? এটা নাম আছে মেথডটা।
Navzinger's sign.
মোটামুটি সবই জানে এটা। এইগুলো বলতে পারলে মোর দ্যান পাস, মানে পাস বললে কম বলা হবে। হ্যাঁ, অনার্স। আর কি জিজ্ঞেস করবো? এদের পার্টগুলো বড় আছে স্যার, আমার মনে হয় ক্লিনিক্সের বেশি জিজ্ঞেস করলে আরও। হ্যাঁ হ্যাঁ, তখন ওদের যদি কিছু কোশ্চেন থাকে, হ্যাঁ তোমাদের যদি কোনো কোশ্চেন থাকে স্যারদের জিজ্ঞেস করো।
Sir, in the summary, do we have to mention that it is a probable thyroid swelling? When we are mentioning the examination points, that there is a lateral extension, superior extension, inferior extension. So we just have to write the positive points or the examination points.
Probable thyroid swelling.
Yes, sir. Like, sir, summary te jemni lekha chilo that it is maybe it is a thyroid swelling.
Huh?
Sir, summary te likha chilo maybe it is a thyroid swelling, which indicates it's a thyroid swelling.
না না, ওটা জানি না কি লেখা আছে, প্রবাবল টোবাবল লেখার কোনো দরকার নাই।
Actually, you want to ask now, what will be the provisional diagnosis? You know, I think most of the time it will be solitary nodular goiter or multinodular goiter, probably benign or malignant, that you can mention. Or if there is a features of hyperthyroidism or hypothyroidism, you can mention with that. But the main diagnosis, I think it will be nodular goiter or multinodular goiter. Okay, goiter means thyroid enlargement. It's nothing else. So I just want to ask you, or I just want to discuss something about the investigation of any solitary nodular goiter or thyroid swelling, whatever. Any one of you, what are the investigation that you would like to do to reach a diagnosis for a case of thyroid swelling or solitary nodular goiter, multinodular goiter, whatever?
So first we'll have to get the thyroid profile done. whether the patient is euthyroid, hyper or hypothyroid. Then ultrasound of the neck as per the thyroid scoring, and FNAC and the Bethesda scoring has to be.
Okay, so commonly we used to prescribe the USG and the thyroid function test and the FNAC routinely in our prescription, but as per ATA guidelines and all this, if you follow the algorithm, then first thing that you have to do, what's mentioned, that is thyroid function test, TSH. Okay, that is the first investigation tool, and depending on the thyroid function or state of thyroid, I mean euthyroid or hyperthyroid or hypothyroid, we will proceed next to investigation. Okay, so if it is hyperthyroid, that means TSH is low, then you have to do iodine scan or technetium scan to denote the hot nodule, cold nodule, whatever. When it is hypothyroid, that means TSH high or euthyroid, you have to go for ultrasonography. Okay. Again, in the ultrasonography, all of you have to know about the thyroid score. Okay, ACR thyroid score. What is thyroid score? What is the full form of thyroids? Thyroid imaging. চাঁদা তুলে না একজন বল thyroid imaging reporting data system. So what are the types of thyroids? 1, 2, 3, 4, 5. So what is 1? So there are certain points that you have to keep in your mind, and according to these points you have to score. And with the score there are division of 1, 2, 3, 4, 5. 1 means 0. When score is 0, that means thyroids 1. When score is 2, thyroids 2. When score is 3, thyroids 3. When score is 4 to 6, thyroids 4. And 7 or more is thyroids 5. So again you can divide it that thyroids 3 is mildly suspicious, thyroids 4 is moderately suspicious, and thyroids 5 is okay. And depending upon the thyroids, we will go for FNAC. Before that, I just want to know about the certain points that we assess to make the score. What are the points? There are 5 points. Tell me if you know it.
So, shape, ecogenicity.
Okay, so first is shape. Then?
Ecogenicity.
Ecogenicity.
Isoechoic, hypoechoic.
So it may be hypoechoic, isoechoic, very hypoechoic. So you can understand if it is very hypoechoic, then it will be, score will be high. Then
taller than wider or wider than
what do you mean by taller than wider and wider than taller?
Wider than taller is benign, sir, 0 scoring. And if it is taller than wider, then it will be 3 scoring. That is
so you want to say if it is taller than wider, then score will be high.
Higher.
So what do you mean by taller, and how will you measure it?
In the ultrasound features of whether the swelling is the transverse diameter is more than the vertical diameter,
No.
then it is
The anterior posterior diameter, that is measured. So you are seeing the in sagittal section. So the anterior posterior diameter will be the taller if it is more than the wide.
Width.
Okay. So taller than wider is obviously score will be high. So 3 points and another 2 points.
Then any echogenic foci.
Echogenic foci. Yes. So punctate echogenic foci obviously will be high score, and the macrocalcification and all this will be low score. And the last one, composition. Okay, so the shape, composition,
Cystic,
echogenicity,
solid, mixed.
Huh?
Cystic, solid or mixed.
Okay, so if it is solid, the score will be high, and obviously the margin, that is regular, irregular, or extrathyroidal extension. So first thing after doing the TSH, you have to go for thyroid scoring with ultrasound. So when it is thyroid 3, there are certain measurement. If it is more than or equal to 2.5 centimeter in diameter, you have to go for FNAC. If it is more than 1.5, you have to do follow-up. If it is thyroid 4, if it is more than 1.5, then you have to do FNAC. If it is more than 1 centimeter, obviously, more than equal to 1, then you have to do the follow-up and FNAC. So the measurement is 2.5, 1.5, 1.5, 1, 1 and 0.5 for thyroid 3, 4, 5. 2.5 for FNAC, 1.5 for follow-up. Thyroids 4, 1.5 for FNAC, 1 is for follow-up. Thyroids 5, 1 is for FNAC and 0.5 or equal to is for follow-up. Okay. So these all are about ATA guidelines. and after that you have to do the FNAC. So now in FNAC again you have to do the Bethesda scoring. Okay. So what is Bethesda scoring? Any one of you can tell me, take the microphone.
As per 2023 Bethesda scoring system, non-diagnostic comprises of 14% risk for malignancy. Then comes benign, which is 4% mean malignancy. Then come atypia of unsignified, that is 14% chance of malignancy. Then come follicular neoplasm, that is 22%. And after that, suspicious malignancy, that is 74%, and biopsy proven malignancy is 94%.
So first one is 40. You want to say risk of malignancy, non-diagnostic.
14%. Mean range, means.
Oh, okay, so there was a classification regarding the Bethesda and the percentage of risk of malignancy. It will gives you what to do and give you the clue about the malignancy. Okay. There was a lot of debate regarding NIFTP, and if you consider NIFTP as a malignancy, then the percentage of malignancy will be definitely increased, and if you consider as a NIFTP as a benign, then your percentage of malignancy will be definitely decreased. But what you said, that is the Bethesda 3, that newest version.
Yes,
okay, so in the Bethesda 3 or the newest version, that is 23 updated, that Bethesda 1 is non-diagnostic. Non-diagnostic means what you have to do? You have to do the repeat FNAC ultrasound guided. Okay. So if your FNAC report comes Bethesda 1, then it is called non-diagnostic. Then you have to do FNAC again with ultrasound guided. And the average risk of malignancy is 14%, not 40. Average. I am talking about average for one.
Sir, I told 14% only.
14.
14. 14.
I heard that is 40 you said. No? So he is right. So average percentage of malignancy is 14%. The next, second is benign lesion. Okay. The average risk of malignancy is 4%. Average risk of malignancy is 4%. And what to do? You have to do follow-up. Bethesda 2, what you have to do? You have to do follow-up. Now Bethesda 3. That is the indeterminate region, that is OS. The flu's term already gone. There is only AUS, atypia of undetermined significance. What you have to do? You have to do, the risk of malignancy is 22%. Average risk of malignancy is 22%, and you have to do repeat FNAC after 1 month, or molecular testing, or if again that reveals indetermination, and then you have to do diagnostic lobectomy or something else. Okay. So Bethesda 3 is AUS, atypia of undetermined significance. What you have to do? You have to repeat the FNAC after 1 month, and plus minus molecular testing, plus minus diagnostic lobectomy or surgery. Then it is 4, that is follicular neoplasm. Okay, so it is follicular neoplasm, and the percentage risk of malignancy is 30%. Average, I am telling about the average. Average risk of malignancy in case of 4, that is 30%. And what you have to do again? You have to do molecular testing to confirm your diagnosis, or you can repeat the FNAC after 1 month, or you can do diagnostic lobectomy. Now 5, suspicious of malignancy. The Bethesda 5, that is suspicious of malignancy, and the average risk of malignancy is 74%. And here you have to go for surgery. So what recommendation is also there, as per ETA guideline, recommendation is also there, what you have to do. So in case of 5, you have to go for surgery. Whether it is hemi or total, that is different issue. I will talk on later on that. And the 6 is definitive malignancy. And the risk of malignancy here it is 97%. So you have to do surgery. So this is all about TSH, then USG, then FNAC, and what you have to do, that also should be guided by your FNAC report or Bethesda scoring. Now there are certain points where you have to do the molecular testing, that is for Bethesda 3 and the Bethesda 4. What are the molecular testing that you can do? Or genetic testing? Any one of you can. What are the genes associated with the thyroid malignancy? Take the microphone and then I can't hear you. Okay, so there are certain gene and codon and mutation everything you do not need to know in details, but you should know for good scoring in your exam. So first thing is that is what's he mentioned, that is
PPAR gamma gene.
BRAF. Okay, homologous B sarcomoid antigen, that is BRAF B600E mutation. That is common for papillary thyroid carcinoma, and other are RAS and RET, which are very less. HRAS, NRAS, KRAS. And for medullary it is RET PTC. And for follicular carcinoma it is mainly the RAS, and other also involved. And others, what's he mentioned, that is PPAR gamma and PAX8 and all this, galactin 3, these are involved. So commonly the genetic testing is Aprima, GECA or GSC. That is a common test that is available in the market. Aprima, GEC or GSC. GEC is the previous one and GSC is the genetic sequence counseling or genetic expression. So they do the 167 gene expression test with the mRNA, and people used to call it as a rule out test because the negative predictive value and the sensitivity is high for this test. That's why it is called rule out test. By doing this test, you can say that there is a less chance of malignancy. Okay, so there are called certain tests which is called rule out test, certain tests which is called rule in test, which will give where the specificity is high and the positive predictive value high, then it will be rule in test. Okay, so these are the tests, some Thyrosec V3 and 17 gene panel test and all these tests. So this is all about molecular testing, and then CT, MRI, PET CT and all this. Can anyone tell me where you will do the CT, where you will do MRI for thyroid swelling? Any one of you? Take the microphone. Where you will do the CT and when? When there is a retrosternal extension, what you will do?
Retrosternal extension, then we go for CT to
Okay,
look for the extension.
so suppose the FNAC reveals that there is a chance of malignancy and you are thinking to do the surgery, whether it is diagnostic lobectomy or hemi or total, whatever. But suppose there is some certain lymph node. Okay, by doing USG is a very good tool and very sensitivity is there to detect the lymph node also. But sometimes we need to do the CT scan also, CECT. Suppose it is little extensive, extrathyroidal extension is there, and you want to assess the lymph node in proper way in the retrosternal goiter, then you have to do CT scan, that is must. CECT. There is a controversy regarding the iodine with whether we will use it or not, but nowadays there is no controversy. You can use contrast enhanced CT scan because later on we need radioiodine ablation, but you can use it. And when we will do MRI?
Extrathyroidal extension.
That you can assess by doing CACT. It's quite okay. Anyway, in general, MRI is good for soft tissue structure. So if you have any doubt regarding thyroid cartilage involvement, regarding prevertebral soft tissue involvement, you can go for MRI. Otherwise, CECT will be sufficient. CECT neck plus chest will be sufficient for your assessment. Okay. So when there is a thyroid cartilage, because you know the sensitivity of MRI is much more higher than CT in case of detection of cartilage involvement. So thyroid cartilage involvement and the prevertebral soft tissue involvement, you can go for MRI to add on your CECT. So this is all about CECT and the MRI regarding thyroid swelling. Next, there are so many other investigations that is known as thyroid scan and FDG scan, all are there. Do you have any idea about thyroid scan, when to do and where to do? I am talking about iodine 123 scan or 131, whatever. when you will do the iodine scan?
Sir, in subclinical hyperthyroidism.
Subclinical hyperthyroidism. So I mentioned previously in the first at the beginning that if the TSH is low, that means hyperthyroidism, you have to go for scan. That may be iodine 123 scan
Technetium
or
90.
technetium scan. Which one is better?
Technetium 9.
Why technetium scan 99 scan is better?
No, sir.
Half-life is less. If you, there are so many radioactive iodine. 123 we usually use for scan only, diagnostic purpose. But even the technetium 99 whose half-life is lesser than iodine 123, number one, that is 6 hours. Na? Half-life is less. And number two is cost. Cost is also less, I think. And number three, which is most important, availability. Technetium 99, which is more readily available than iodine 23. There are so many papers and legal things are there to get the iodine 123. So these are the thing about iodine 123 scan. And there are certain areas where you have to do iodine scan after surgery, after treatment of the total thyroidectomy, okay?
Total thyroidectomy, we have to go for radioiodine scan. 4 weeks after the surgery, we can go for radioiodine
Okay, so
scan.
after the treatment, I will discuss on that. You will discuss on the treatment and post-operative or post-surgical management part I can discuss, and then I will discuss. And there are certain other scan that you have to know, which is known as FDG PET scan. Where you will do?
Incidental PET scan, incidental
Huh?
PET scan for focal.
No, for thyroid swelling, where you will use it?
In case of malignancy.
So FDG PET routinely not used. There is no as such very important role in thyroid diagnosis, thyroid swelling diagnosis, but you have to do after surgery or when there is no non-iodine avid thyroid residual tumor. So FDG reserved for residual recurrence and all this for recurrence assessment. Even if the thyroid tissue are not iodine avid, then you will not get anything by doing the iodine scan. Then you have to go for FDG PET scan. You understand? And what is iodine 131 MIBG scan? Just you have to know this term, because if you where you will do it? To assess the pheochromocytoma. Okay. So I will discuss the other thing on later on. Prognosis that you will discuss about the.
Yeah. So thank you. We will talk about the treatment. Here I am going to show you certain case scenarios, and we are going to just plain interact that how we are going to treat it. This is obviously an interaction where you are going to answer. I am going to answer. You are going to ask questions. I am also going to ask questions. So the first case, this is a female patient. Whenever we are talking about thyroid swelling, this is the malignancy where age is an important prognostic factor in TNM staging, right? So you have to keep that in mind. This is a 32-year-old female patient. She has come with a 1.5 by 1 centimeter right lobe thyroid SOL, Bethesda 5, TIRADS 4, right? There is no neck node in USG. So what should be the treatment? This is a clean-cut question. This is a normal thing which we get in OPDs. Patient has come after doing the investigations. So what should be the treatment of choice? Primary treatment of this patient. Any one of you from last? What should the treatment? Right? Tell anyone. Stand up. There is no positive family history of thyroid swelling. Why you are going to ask that? Why, right? Why in a 1.5 centimeter by 1 centimeter unilateral SOL you are going to consider total thyroidectomy?
Because
does presence of papillary carcinoma indicate that you are going to go for a total thyroidectomy? So we are going to discuss, right? The ATA guidelines suggest something different. Anyone? Yes.
We can wait for 4 centimeter.
Right.
some says we can go for hemithyroidectomy.
Right.
And it depends on the histopathological report of that specimen. Then you can suggest the further treatment. Otherwise,
What was told by Dr. Animesh was that if you get Bethesda 5, what is the chance of malignancy?
74%.
Right. So with this background, can we think of going for total thyroidectomy? I don't think so. So we are going to go for hemithyroidectomy. Right. So now, after doing the hemithyroidectomy, there are two possible scenarios. Please sit. The HP has come out as classical variant of papillary carcinoma of thyroid. 1.5 by 1 centimeter, classical variant, papillary carcinoma thyroid. How we are going to treat further? Are we going to go for a subsequent surgery? The answer is no. We are going to just wait and watch. Second scenario, the HP is suggestive of either the tall cell variant or diffuse sclerosing variant or a morular cribriform variant. How are you going to treat this subtype of histopathology of papillary carcinoma thyroid? Anyone? These are the poor prognostic types of papillary carcinoma. The classical variant is going to behave entirely different from these subtypes. So how are we going to treat these subtypes? Anyone? From back? Why? Dimension is same. It is a 1.5 by 1 centimeter.
Feature, poor characteristics of tumor, therefore we'll go for completion thyroid.
Right. So the ATA guidelines do have some respective mention about some indications of hemithyroidectomy and indications of total thyroidectomy, right? So we go to the recommendation, right? These are the directly taken from ATA guidelines. It suggests if surgery is chosen for patients with thyroid cancer less than 1 centimeter without extrathyroidal extension and clinical N0, the initial surgical procedure, mind the word initial surgical procedure, should be a thyroid lobectomy unless there are clear indications to remove the contralateral lobe. That means if you get a malignant lesion, you must not jump for thinking about total thyroidectomy. There are some specific indications for total thyroidectomy, which someone of you just said, more than 4 centimeter, that sort of. But there are other indications of total thyroidectomy also, right? So what is the protocol? If the size of the tumor is less than 1 centimeter, if the age of the patient is between 15 to 55 years, if the age of the patient is between 15 to 55 years. Number 3, if it is a unifocal tumor, if it is multifocal, multicentric, that means the tumor has involved both the lobes. In that case, you go for total thyroidectomy. If it is an unifocal lesion, you are going to go for hemithyroidectomy. Number 4, if the lesion is not on the surface with extrathyroidal extension, that means suppose there is a 1 centimeter lesion, it obviously will be in T1. However, if it encroaches the surface and it involves the surrounding structures like the strap muscles, it is immediately upstage to T3. So in spite of the size being 1 centimeter, the tumor with extrathyroidal extension has to be upstage to T3. So in that case, you will treat it by total thyroidectomy. Number 5, if there is central or lateral neck nodes. Number 6, if there is evidence of distant metastasis. I again repeat, age. Number 2, size. Number 3, focality, that is unifocal or multifocal. Number 4, the type of histology. Classical variant, you go for hemithyroidectomy. Atypical variants with poor prognosis, you go for total thyroidectomy. Number 5, extrathyroidal extension. Number 6, lymph node involvement. Number 7, distant mets. These are the 7 indications where you need to think whether you want to go for hemithyroidectomy or total thyroidectomy, right? So, now, this is the brief mention about the atypical variants, which actually we don't read in the histopathology report. This is the tall cell, this one is the tall cell variant, this one is the oncocytic variant, diffuse sclerosing variant, follicular variant and columnar cell variant. There is one variant called the morular cribriform pattern, which actually is associated with familial adenomatous polyposis coli. That means if the patient comes with histopathology of morular cribriform pattern, don't forget to send the patient to your GI colleagues for an upper GI endoscopy or colonoscopy, right? So morular cribriform pattern is inherited by a genetic mutation, which is also expressed in familial adenomatous polyposis coli, right? So, now, this is another scenario where you are getting a 3 centimeter by 3 centimeter SOL, thyroids and Bethesda same, there is no lymph node. How are you going to treat it? This is not 1.5 by 1 centimeter. This is 3 by 3 centimeter, and hence the staging is, what is the staging? Can anyone stand up and tell the staging? Anyone? Just try, no? T? What is the staging? Normal, what is the staging? TNM staging of thyroid malignancy? Don't Google. T1 can be further divided into T1A and T1B, because papillary microcarcinoma is having an excellent prognosis where you can also wait and watch. So if it is less than 1 centimeter, it is T1A. If it is 1 to 2 centimeter, it is T1B. Why this differentiation has been done? Because T1A carries an excellent prognosis, and most probably it may not even require surgical interventions. So T1A is less than 1 centimeter, T1B is 1 to 2 centimeter. That is T1. T2, like all other head neck malignancies, 2 to 4 centimeter. T3 is more than 4 centimeter, or any dimension with extrathyroidal extension with involvement of immediate strap muscles. That is T3. T4, 4A and 4B. Remember, 4B is involvement of carotid, prevertebral fascia and the mediastinum. That means rest of the adjacent structures will be T4A. That is trachea, esophagus, recurrent laryngeal nerve, okay. Immediate involvement of the adjacent structures, muscle involvement is T3, rest of the other structures involvement is T4A, prevertebral fascia, mediastinum and carotid involvement is T4B. So this fits into T2N0MX, right? Now, if the patient is having N1 instead of N0, will the stage change? If the patient is having N1 instead of N0, will the clinical staging change in the background of a 32-year-old female patient? Can anyone tell? The TNM staging, as I just mentioned, age is an extremely important prognostic factor, right? So less than 55 years, there are only 2 stages, stage 1 and stage 2. Stage 1 means NET, NEN, M0. Stage 2 is NET, NEN, M1, right? So distant metastasis is stage 2, less than 55 years. And more than 55 years, that stage 1, stage 2, stage 3 and stage 4 we define. So I again repeat, when you are treating a patient who is in the good prognostic age group, and here I am not talking about the pediatric thyroid malignancies because they overall carry a very poor prognosis. So I'm talking about 15 to 55, which was previously 45. So in 15 to 55 year age group, you have stage 1 and stage 2. Stage 1 is NET, NEN, M1. Stage 2 is NET, NEN, M0, and stage 2 is NET, NEN, M1. That means lymph node involvement significantly does not affect the prognosis and the survival. I again repeat, lymph node involvement significantly does not affect the prognosis and survival. So, how are you going to treat this patient? It's a controversial thing. You can treat it by hemithyroidectomy or you can treat it by total thyroidectomy. So, this is the ATA guideline. What it reads: for patients with thyroid cancer, more than 1 centimeter but less than 4 centimeter without extrathyroidal extension, without clinical evidence of any lymph node mets, the initial surgical procedure can be either a bilateral procedure, near total or total thyroidectomy, or a unilateral procedure, lobectomy. Now this guideline is ATA guideline 2015. The coming guideline is going to come in the next year only, right? So this clearly mentions regarding the aggressive surgical procedure, radical procedure, total thyroidectomy or lobectomy. Thyroid lobectomy alone may be sufficient as initial treatment for low risk papillary and follicular carcinomas. However, the treatment team may choose total thyroidectomy to enable radioiodine ablation or to enhance the follow-up. Am I clear in this? Any patient of 2 centimeter, 2.5 centimeter, 3 centimeter malignancy may develop a subsequent thyroid malignancy in the lobe which you have already retained if you are going for hemithyroidectomy. Naturally, if the whole thyroid gland has not been removed, you cannot go for radioiodine ablation. There is a definite possibility that subsequently the tumor may come back. So if you think that you do have absolutely excellent expertise in going for total thyroidectomy without giving any complications, you can go for total thyroidectomy in 1 centimeter to 4 centimeter lesion. But if you go for a hemithyroidectomy, there is nothing wrong and you have to go for a meticulous follow-up. So 1 to 4 centimeter is the gray zone, which depends upon institutional practice, which depends upon personal preference, which depends upon your own expertise. Clear? Next. This is a case, I have put the same picture because I did not have the picture. So this is a 4.2 by 2.5 centimeter swelling in the right lobe of thyroid with the same thyroids and Bethesda, N0 neck. What you are going to do? Just say no, that will be a better interaction. Right, you are going to do total thyroidectomy. Next question, are you going to do the central neck? Yes or no? This is N0. Are you going to do the central neck? Yes or no? If yes, why? If not, why? You are going to do total thyroidectomy, there is no controversy in that, right? So whether central neck nodes have to be removed, mind it, this is N0. As Dr. Animesh had mentioned about the investigations, when you are investigating, you do the USG, right? He mentioned about CT scan. One of the important indications of CT neck in case of thyroid swelling is you need to assess the central neck nodes, right? So even if the neck nodes status is N0, suppose Animesh can do it very well, suppose I can't do it at all, right? If he does central neck and I am not doing central neck, after 5 years, what is the chance of malignancy in the neck nodes if I am not doing it? Anyone? I again repeat it. Total thyroidectomy, both of us have done. It is N0, T4. He has done a central neck without complications. I have not done a central neck, obviously no complications. What is the probability of neck node locoregional recurrence after 5 years? It is less than 5%. Right. That means lymph node involvement is not that prognostically important. So central node dissection is again a matter of personal expertise, your institutional preference, your own preference. No controversy regarding total thyroidectomy, but lymph node dissection, central neck in a N0 case. I again repeat it. Not in case of N1. When there is definite N0, as confirmed by clinico-radiological evaluation, if you are not doing central neck, there is nothing wrong in it. It is better if you are doing central neck. That depends upon the expertise. So, total thyroidectomy with or without central neck dissection. This central neck dissection will obviously be a prophylactic neck dissection rather than a therapeutic neck dissection because this is N0. So, what is the recommendation? For patients with thyroid cancer more than 4 centimeter or with gross extrathyroidal extension clinically T4 or clinically apparent metastatic disease to nodes clinically N1 or distant sites, the initial surgical procedure should include a near total, I don't know about near total, or total thyroidectomy and gross removal of all primary tumor unless there are indications to this procedure. So there is no controversy. I again repeat, to summarize, less than 1 centimeter, 1 to 4 centimeter, more than 4 centimeter. Less than 1 centimeter, you go for conservative. More than 4 centimeter, you go for radical. 1 to 4 centimeter is a gray zone. So these are the indications of total thyroidectomy, right? Which I just mentioned. Age, this is more than 40, this is 45 years, but actually the guideline now has been shifted to 55 years. That is age, number 2, history of radiation, number 3, lymph node distant mets, bilateral nodularity, extrathyroidal extension, tumor more than 4 centimeter, we will go for total, cervical lymph nodes and aggressive variant, right? So what I mentioned, those 7 points, no, they are mentioned in the textbooks. age, number 2 size, number 3 multifocal or unifocal, number 4 type of histology, number 5 extrathyroidal extension, number 6 lymph nodes, number 7 distant meds. This is the another scenario which I just discussed. This is a 3 by 2 centimeter thyroids for Bethesda 5. What you are going to do with N0 and what you are going to do with N1. Just as we mentioned, with N0, the lymph node dissection is prophylactic, depends upon your personal choice. If however it is N1, N1 is N1A and 1B. 1A is involvement of level 6. What about level 7? Superior mediastinal lymph node involvement is 1A or 1B? 1A, that's right. Mediastinal lymph node involvement is not 1B. 1B is 2, 3, 4. 1A is 6 and subsequently 7. Right? 1A is 6 and subsequently 7. 1B are 2, 3, 4. So these are the recommendations regarding neck dissection. Therapeutic central node, level 6 node dissection for patients with clinically involved central nodes should accompany total thyroidectomy to provide clearance of disease from the central neck. Mind the word therapeutic neck dissection. Prophylactic central compartment neck dissection, ipsilateral or bilateral, should be considered in patients with PAP-CA with clinically uninvolved central nodes, that is N0, who have advanced primary tumors T3 or T4, or clinically involved lateral neck nodes N1B, or of the if the information will be used to plan further steps in surgery. So these are all the ATA guidelines which you need not remember by heart, but just you need to know the basics, right? Now we are going to discuss in brief about the medullary thyroid carcinoma, right? So this patient, 3 by 2 centimeter thyroid SOL, right? You have put the needle, I mean the pathologist have put the needle, and the report has come out as medullary thyroid carcinoma. So how are we going to work up the patient? Anyone? The guidelines have been mentioned. So what is the initial investigation and workup and why? Can anyone say? You speak. Anyone? What are the initial investigations? What? So calcitonin, why? This is the primary case which you are dealing. You have not yet talked about the surgery. Calcitonin is the perfect. Calcitonin is a biomarker. So what about medullary thyroid carcinoma? What is the site of origin? They originate from the parafollicular C cells. So what we discussed till now is the follicular cell. Apart from that, there should be another cell called the parafollicular C cells. These parafollicular C cells secrete certain chemicals which actually starts with C. This is how I teach the PGTs. Number 1, calcitonin. Number 2, chromogranin. Number 3, calcitonin gene related peptide. Number 4, carcinoembryonic antigen. Number 5, cytokeratin. So these 5 C's are secreted by parafollicular C cells. I again repeat. Number 1, calcitonin. You all know that. Add up calcitonin gene related peptide. Number 3, carcinoembryonic antigen. Number 4, cytokeratin. And number 5, chromogranin. These 5 C's are secreted by parafollicular C cells of thyroid. Right? So, whenever the medullary thyroid carcinoma comes to your mind, the another thing which should hit you is MEN syndrome. Right? You forget about MEN 1. What is MEN 1? Pancreas? Pituitary? Right. So, pituitary, parathyroid and pancreas, this forms MEN 1. Remove the thyroid from it. Now come to MEN 2A, 2B. MEN 2A, components? Medullary thyroid carcinoma, pheochromocytoma, and parathyroid involvement. So thyroid, parathyroid and pheochromocytoma. So you have to mark certain biochemical markers of these 3 diseases. So calcitonin for medullary carcinoma of thyroid, calcium for parathyroid, and catecholamines for pheo. So those catecholamines urinary catecholamines or plasma-free catecholamines, that is epinephrine, metanephrine and normetanephrine, right? So I again repeat, 3 biochemical tests you do. Number 1, calcitonin. Number 2, calcium. Number 3, urinary catecholamines 24-hour or plasma-free metanephrines and normetanephrines. That is biochemical evaluation. Number 2, you do the radiological imaging. So for radio imaging, you have to believe on the expertise of an expert sonologist who will be able to say whether only the SOL is present in thyroid gland and or the parathyroid gland is also involved, and is it a sort of parathyroid hyperplasia or a parathyroid adenoma, because the treatment is going to be different. And you have to do CT abdomen in order to exclude pheochromocytoma, right? So this is the routine radio imaging which we used to know. But as Animesh mentioned about the radionuclide imaging, the medullary carcinoma of thyroid expresses somatostatin receptors. So if you give a radionuclide dye which contains somatostatin analogs, there will be uptake, and hence in a single view you can mention whether the site of origin is unifocal or it's a part of the main complex. That is gallium-67 dotatate PET scan. That is gallium, I have not mentioned. That is gallium-67 dotatate PET CT scan, right? So this radio imaging is not only used for diagnosis but is also used for therapeutic purposes. So I again repeat, the biochemical evaluation, calcitonin. Number 2, calcium. Number 3, catecholamines. Number 2, radiological evaluation. Number 1, USG. Number 2, CT. Number 3, radionuclide scans. Now comes the most important part, that is the genetic analysis of the RET. What is the full form of RET? Anyone? What is the full form of RET? Full form of RET is rearranged during transfection. RE stands for rearranged, T stands for transfection. So this RET proto-oncogene is present in 10th chromosome, long arm 11.2, that is 10q11.2. So RET proto-oncogene is expressed in 10q11.2. They expresses certain proteins, that is tyrosine kinase transmembrane protein. So there are certain mutations in specific codons which, if properly done, you can actually prognosticate the patient. That means I am having a medullary carcinoma of thyroid, suppose, how my MTC is going to behave, whether it's going to behave very aggressively or it's going to behave in an indolent fashion, that is to be judged by genetic analysis. So there are various codons. One we classified into highest risk, intermediate risk and high risk. Sorry, highest risk, high risk and intermediate risk. Achha. So how are you going to treat it? We are going to treat this case by total thyroidectomy with neck dissection. Whether patient is having N0 or the patient is having N1, in this case we have to treat the patient by a radical surgical procedure of total thyroidectomy with neck dissection. How are we going to follow up the patient? Follow-up of the medullary carcinoma has to be done by 2 ways. Number 1, as someone mentioned about calcitonin initially for follow-up, calcitonin and calcitonin doubling time is used for follow-up of medullary carcinoma thyroid, and obviously we have to go for radionuclide scanning. One important concept is surgical procedure is prophylactic thyroidectomy. What do you mean by prophylactic thyroidectomy? Prophylactic thyroidectomy means the patient is affected by MTC, you have done his genetic analysis and you have stratified his genetic setup into highest risk, high risk and intermediate risk. Codon 883 and 918, if there is mutation in that, it implies that the child of the patient, even if he is less than 1 year of age, he may develop medullary carcinoma of thyroid, and hence you have to go for prophylactic thyroidectomy. Total thyroidectomy, neck dissection is not indicated. I again repeat. So prophylactic thyroidectomy means the child has inherited the genetic mutation from his parents. Depending upon the risk of mutation, it can be highest risk, high risk and intermediate risk. Depending upon that, the highest risk codons, the surgical intervention has to be done before the age of 1 year. In high risk, it has to be done before the age of 5 years. And in intermediate risk, it has to be done before the age of 10 years. That is 1 year, 5 year and first decade. So this is called prophylactic thyroidectomy. Now, what are the different, continue Karbo. Acha. Now, what are the different complications we get after thyroid surgery? So these are the complications which are enumerated, right? But I want any of you to stand up and say, what are the different complications of after thyroidectomy? Anyone? Just stand up and say no. What are the complications of the thyroid surgery? This is a very basic question. Okay. So, but these are the questions which are asked routinely during exams, right? So these are the questions, the complications in brief: hemorrhage, infection, recurrent laryngeal nerve palsy, the thyroid crisis or the thyroid storm. You will be asked, how are you going to manage a case of thyroid storm? Respiratory obstruction, parathyroid insufficiency or tetany. So the complications which you are supposed to know, rather definitely you are supposed to know, they are: number one, why the patient will have respiratory distress after thyroid surgery. It can be, number one, because of hematoma. It can be because of bilateral recurrent laryngeal nerve palsy, which obviously you are not going to do unless you are doing surgery very badly. So bilateral recurrent laryngeal nerve palsy may present with respiratory distress immediately post-op, or if there is a hemorrhage, there will be respiratory distress. Number two, day 2 to day 5, you are going to monitor for parathyroid insufficiency. So you are doing the surgery today on Thursday. On Saturday morning, you have to send the blood for serum calcium. And you have to monitor if there is hypocalcemia. You have to ask the surgeon whether the color of the parathyroid gland actually changed during the surgery. If the color of the parathyroid gland had changed, whether you have done the auto implantation or not. If auto implantation has been done, whether it has been done in the brachioradialis or in the sternocleidomastoid. For malignancy, you don't do auto implantation outside the neck, right? How are you going to treat a case of hypocalcemia? All of you have done in your wards, surgical wards as well as ENT wards. You give calcium gluconate. Gradually you taper off the dose. Importantly, there are two types of hypocalcemia which you are supposed to know. One is temporary hypocalcemia. One is the permanent hypocalcemia. Temporary hypocalcemia will occur obviously because you are handling the parathyroid glands. So the parathyroid gland is actually extremely sensitive. Even if you are handling it, even if you are dissecting it, there is definite evidence of ischemia which will be manifested in the post-op period as temporary hypocalcemia, which after few days will become normal. Unless you have damaged all 4 parathyroid glands, which is actually very rare and we don't see, patients are not going to develop permanent hypocalcemia. These are the late complications: thyroid insufficiency, recurrent thyrotoxicosis and progressive exophthalmos. These we don't get because we are dealing only with the malignancy cases and hypertrophic scar or keloid. So these are the mentions about the recurrent laryngeal nerve palsy. If whenever you are asked about the recurrent laryngeal nerve, the examiners will be asking you 2 atypical questions. What is non-recurrent laryngeal nerve? And if there is, what is the incidence of bifurcation or trifurcation of recurrent laryngeal nerve? I again repeat, what do you mean by non-recurrent laryngeal nerve? Is the non-recurrent laryngeal nerve associated with any other condition? Right, that is dysphagia lusoria. And third, what is the incidence and prevalence, rather incidence of bifurcation or trifurcation of recurrent laryngeal nerve? These all will be available with you in your So what are the findings of superior laryngeal nerve palsy? After superior laryngeal nerve palsy, that is why we asked that, we should be very cautious when we are dissecting the upper pole of the thyroid gland. We should not be in haste and clamp the whole of the upper pole. Superior laryngeal nerve palsy patients will not have any alteration of voice, but rather the patient will, he or she will say that when he or she is raising the pitch, he or she cannot raise the pitch properly, which implies that the superior laryngeal nerve might have been injured. Bilateral superior laryngeal nerve palsy may result in aspiration because superior laryngeal nerve supplies the supraglottic larynx. So how will you manage post-op RLN and SLN palsy? cause of respiratory obstruction after thyroid surgery. Okay, so we have read that when there is severe hemorrhage, there is patient is having respiratory distress, right? So why there is respiratory distress? Do you think that the blood clot compresses the trachea? The blood clot actually cannot compress the trachea. As a consequence of the blood clot, there will be submucosal edema. The venous drainage will be hampered. That is the reason why the patient will have respiratory distress. It is not possible that a blood clot of even 300 gram or 400 gram can compress upon the trachea. So much so that the patient is having respiratory distress. Because of as a consequence of formation of the blood clot, there will be submucosal edema, intraluminal edema, as a consequence of which the cross-sectional diameter of the lumen will decrease. That will result in patient developing respiratory distress. So as soon as you make an incision, you remove the blood clot, obviously the edema will go away. So these are the cause of hypoglycemia after surgery, parathyroid insufficiency. What are the precautions that you do to prevent it? Treatment of hypocalcemia. So I think that is in nutshell the presentation about the complications. Thank you, sir.
Thank you. Any question? Yes. Any question from you? অনেক পড়ানো হয়ে গেছে. Yes.
Incidence of bifurcation or trifurcation of RLN ওটা কোথায়?
Sir, if there is a diagnostic dilemma regarding the neck nodes, can we go in for a sentinel node biopsy?
So sentinel lymph node biopsy is important for N0. Okay. When clinico-radiologically N is 0, I don't think for thyroid malignancy we have to do sentinel lymph node biopsy. I will not say that it's bad, but still now nobody is doing that. Only oral cancer with N0, they are thinking about sentinel lymph node biopsy to decrease the burden of prophylactic neck dissection. You understand? But the lymph nodal status is not so much important here in thyroid. So I don't think it will be cost effective.
Sir, actually, sir mentioned about doing prophylactic neck dissection.
Prophylactic of what?
Sir, in N0 cases.
Okay.
In thyroid malignancy. So in that case, rather than doing a prophylactic neck dissection,
no,
can we?
There is no hard and fast rule about the prophylactic central compartment neck dissection in N0, clinical radiological N0. In expert hand, and if it is a T3 disease, up to T3, or a T2, T1 disease, it will be better if you do not do the neck dissection, central compartment neck dissection. You understand? But if there is some, malignant potentiality or adverse sign, then only you can, with your expert hand, then only you can do the central compartment neck dissection in N0. And for that girl, knowing the percentage of hypocalcemia, I think it is more important how to manage the hypocalcemia according to the level of the calcium. That is more important. Okay. And your examiner may ask you.
What is said is perfectly right. We define sentinel lymph node biopsy only in case of oral malignancies. For thyroid malignancy, lymph node dissection, as you correctly said, T1, T2, you are not going to do prophylactic neck dissection at all. What I mentioned is advanced malignancies with poor prognostic factors, you may do or you may not do. Even if you don't do, it is not any harm. The patient is not going to come with locoregional recurrence as frequently as in oral CA or any other malignancies. So that is exactly what is the message.
Mainly it is your decisions during the thyroid surgery. The central component nodes are not usually seen in the USG, and we are not doing routinely CT scans. So during surgery, you will examine the central component nodes, and if you think it is a enlarged lymph nodes, it may be a malignancy, so you will remove it. This is the dictum.
Thank you, sir. Thank you very much, sir.